Okay, so my lecture for today will be on Cabinet 7. My cabinet is all about the permitted antimicrobials. I have IV, cephalosporins, IV, IV penicillins, then oral na um, penicillins and oral cephalosporins and mga aminoglycosides, mga macrolides. So, my lecture would cover not only those naiuban nga parts na because this is all about the antimicrobials as a whole. So, my lecture would cover also those na antimicrobials na dili siya available diri sa pharmacy. So, it would also cover na uban nga parts na mo cover sa katong previous nga cabinet cabinets which is from Ma'am Jeka. So, please bear with me na lang. So, I would like to acknowledge the information I am going to share to you is taken from the antimicrobial therapy supplementary handouts from Dr. Imelda G. Pena of UP College of Pharmacy. So, we'll start now. Cabinet 7, permitted antimicrobials. So, in the antimicrobial therapy, um, there are two approaches in the treatment and effect of infectious disease, which is they are the empiric therapy and the directed therapy. Empiric therapy involves early intervention for life-threatening diseases, which includes history
Sorry.
taking. Yes, hello. Wala na share screen for OL. Ah, kana makita na ninyo?
Yes, sir.
Yes,
Okay.
Yes, sir.
So I'll go ahead and proceed. So there are two approaches in the treatment of infectious disease. That is the empiric therapy and the directed therapy. So empiric therapy involves early intervention for life-threatening diseases, which includes history, physical examination, and clinical experience of the clinician or the doctor. It chooses agents based on patient and the infection. So, ang empiric therapy is muna siya ang first approach in the treatment of infectious diseases. So, when a patient comes to the hospital, like for example, sa emergency room siya, kay like for example, ga-fever siya, dayon, na siya yung mga ipambati, like ga-fever siya, gasuka-suka, or kanang gasi pangihi, or sa na. Then, so i-assess siya sa doctor, mag take og patient history then na magkuan mag physical examination then mag-order og mga test ana. So empiric kung makasuspect ang doktor nga kuan like kung based sa kuan sa doktor evaluation niya na ay kuan infection ng patient, so kailangan siya mo start og antibiotic. Ang iyang unang approach is the empiric therapy. Sa empiric therapy is wala pa siya, ang doctor is dili pa sigurado nga kaning na ay infect kanang no um based on sa iyahong examination nagsuspect siya nga na ay infection but dili pa sigurado ang doctor unsa nga microorganism ang kuan naka-infect sa patient. So, kailangan siya kanang kanang muhatag og antibiotic para ma-prevent ang sepsis. So, ang sepsis is ang pinaka kanang taas ng kuan sa infection. which is murag nikalat na uh, sa dugo sa patient. So whole system na ang kanang infected. So magkuhan siya, mag-empiric therapy siya. So based on ihang clinical practice, also pwede po mo based ang doctor sa antibiogram. So hospitals have an kuan mga hospitals usually na ana siya ay antibiogram. An antibiogram is a periodic summary of antimicrobial susceptibilities of local bacterial isolates submitted to the hospital's clinical microbiology laboratory. So antibiograms are often used by clinicians to assess local susceptibility rates as an aid in selecting empiric antibiotic therapy and in monitoring resistance trends over time within an institution. So ang antibiogram is basically kuan ni siya kanang lista ni siya results ni siya sa mga kuan culture and sensitivity test gani. Di ba kay sa hospital is naaman siya microbiology laboratory sa clinical laboratory. Like for example, diri sa SRMC, naami microbiology laboratory na capable of performing culture and sensitivity test sa mga patient specimen. So, ang microbiology laboratory, di ba, sila man mo imo test, then ang katong ilahong mga culture and sensitivity results nga na kuha is i-compile na nila then magama na sila at the end of the year i-summarize na nila dayon kuan i-compile nila kung unsa ilahong mga na-isolates based on sa mga patients na kuan. For example, karon ni year from bali ang antibiogram karon nga year is based on the last year na 2022 nga mga kuan culture and sensitivity test. So, naadiha siya ang lista. Ang lista is katong like for example, naka-isolate sila og Neisseria gonorrhea, mga Clostridium difficile, dayon kuan na nila, i-compile na nila then lantawon dito kung unsa ang mga kanang kuan ang mga microorganisms ang mostly na-isolate sa past year. Then also, unsa ang ilahong sensitivity kuan results. Like for example, if mabutang dito nga kanang mostly ang mga like for example mostly kuan kanang sa ni resistant sila to sa furoxime ana dayon ang mga kuan unsa pod ang usual nga mga susceptible. Like for example, susceptible sila sa ang mga microorganisms to meropenem, mga carbapenems, mga fourth generation cephalosporins. So, ang kuan ana ang mga doctors sa empiric therapy pwede po sila mo base ato dito kay murag kuan man to siya kanang valid man to siya nga kanang results gani. So possible makita dito ang kuan nga unsay possible for example if UTI unsay mga possible nga microorganisms. So base sila dito latawon nila dito kung unsay mga usual nga microorganisms nga na-isolate sa previous nga year dayon based on that kung unsa microorganisms so mag-start na sila og kanang empiric therapy nga kuan like for example katong sa previous year is kanang na ay mga like for example na ay UTI ang patient. So if ever like for example na E. coli ang patient nga na-isolate based on sa antibiogram na ay usual nga mga E. coli ana then so mukuha na ang mga doctors og kanang treatment for E. coli may na. So, and also, i-base po nila sa history sa patient kung wala ba po previously, wala ba po within the month or previous months nga if nakatake na ba po ang patient o lain nga antibiotic, self-medicate ba sila. So, lantawon po na nila ang patient's history. Kay like for example, if sa antimicrobial therapy manggod, kung unsa gani ang previous nga like for example ang imong gihatag nga kuan, imong gihatag nga antibiotic karon is like for example wala na ayo ang patient dayon ang pagka kuan time to time ana kanang if daghan na kaayo wala ra gyapon ang maayo ang patient, so ang kuan sa antimicrobial therapy is pilion nimo ang unsa nga antibiotic ang susceptible sa imong microorganism nga wala pa nagamit. So possible dili na ka mo gamit og kanang katong sa previous nga antibiotic niya kay wala man siya naayo ato. Una makabantay bitaw mo sa katuganing sa lista namo nga mga kuan, sa lista namo nga mga kanang due dates gani sa mga antibiotics. Nay uban dito nga like for example ang patients is dugay na kayo pila na ka months nga kuan, pila na ka months siya nga na-admit diri sa hospital. Dayon kuan kanang sa lista niya is daghan na kayo halos tanan na for example naka piperacillin tazobactam na siya, naka meropenem na siya, dayon naka sa F5 na pud siya. So magpa kung hantod nga dili makuan ayo ang patient, so magkadugang-dugang ra gyud ang ihang mga classes of antibiotics na nasungian. So that is empiric therapy. Then choose agent based on the patient and the infection, then clinical efficacy for adverse drug reactions and pharmacokinetic profile and the cause of the patient, lantawon, then monitor and modify based on patient's response for efficacy and toxicities. Then another approach in the treatment of infectious diseases is directed therapy. Directed therapy determines susceptibility of pathogens to specific antimicrobials. Choose agent based on pathogen, patient, and infection. So directed therapy is kanang mas klaro na ni ang directed therapy. Ang kay kuan mo gi-direct na nimo ang imong treatment based on based on microorganism nga na-isolate nimo sa culture and sensitivity test. So dapat diri sa empiric therapy, dapat sa kuan gyud sa antimicrobial therapy gyud is dapat before ka mo start og empiric therapy, before the first dose of your antibiotic na ihatag, dapat nakakuha na ka og specimen nimo para sa kanimong culture and sensitivity test. Like for example, if kuan ang patient is ni ani diri sa hospital kay murag naa siya'y samad nga dugay na kaayo kanang ang samad niya gani nga kanang murag hubag na kaayo nga dako na iyahong samad, so possible na na siya infection. So before ang doctors ana or nurses instructed na sila ang mga nurses instructed na sila nga before sila muhatag o kanang antibiotic is kailangan kung na-order nga culture and sensitivity test, kailangan makakuha na sila og specimen gikan for example dito sa wound sa patient. Like for example na ay cellulitis ang patient, so anang grabe na kayo iyahong samad, then mag antibiotic na. So before mo start ang iyang antibiotic, first dose sa iyang antibiotic, dapat naka-call na sila sa laboratory, naka-charge na sila og kuan, then naanay request for kanang specimen collection. Kay para pagkuha nimo dito is wala pa'y antibiotic sa system sa patient. Kay pwede man nga ma-alter ang imuhong specimen collection kung nakahatag na og antibiotics, especially if IV mga antibiotics, di ba? Kay if IV is 100% available na siya, din mo dali ra kay na siya nga mo travel sa patients kanang sa lawas sa pasyente through the kuan circulatory system, di ba? So dapat before ang imong specimen is wala pa'y naka-act dito nga kanang antimicrobial prior to prior to the collection of the specimen. So dapat kato specimen usa mo start og antibiotic gyud. So ang mahitabo ana ang specimen is isend nila sa laboratory for microbiology laboratory for culture and sensi. Then after one day after 24 hours, usually mo release na si microbiology laboratory o if na request for gram staining, um, if na request for gram staining, usually after 24 hours mo release na si kuan microbiology laboratory og result sa gram staining. So makita dito if kuan ba siya, if gram negative ba ang imong microorganism or gram negative. So dito pa lamang daan makabalo ka o unsa nga antibiotics imong kuan. So murag na filter na nimo daan, na filter na nimo daan ba kung unsa nga imong antibiotic for gram negative ba or for gram positive. So kung ah kung makabalo na ka gram negative or positive, so murag ma-filter siya. So more specific ng imong antibiotic. Dayon after 3 to 5 days, mo release na si microbiology laboratory og kanang results sa culture and sensitivity test. Murag na ako'y nakuyog ninyo sa una sa mga rounds nako nga akong gi-present ang katong kuan um results sa culture and sensitivity. So like dito sa chart, so ang dito is nakabutang dito kung unsa nga specimen ang kuan gigamit, like for example endotracheal aspirate if kuan ang patient sani kang kuan kini tubig intubate. Dayon naa po dito ang unsa nga sa taas nga part is unsa nga microorganism na isolate, like for example strep pneumoniae ana. Then also na dito sa silong katong naay table na dito ang mga kanang mga antibiotics, like for example resistant resistant dayon mga kuan kanang medium sensitivity, dayon highly sensitive nga mga kuan mga antibiotics. So kung like for example if sa directed therapy, if ang previous nimo sa empiric therapy nimo is kanang pag-abot dito sa imong kanang result sa imong kanang result sa imong culture and sensi, if naa dito nga ang katude imong sa empiric therapy nimo nga antibiotic is resistant day ang patient. So sige ra gyapon og galantaw sa patient nga kanang sige ra gyapon ang iyahong fever, dayon taas ra gyapon iyahong mga WBC ana. So pag ma-confirm dito nga katude ang akong previous nga antibiotic nga kuan is resistant dito siya. So wala gid siya effect sa kuan, wala siya effect sa patient kay resistant naman ang antibiotic, ang microorganism sa antibiotic nga gihatag. So mas syada dito sa directed therapy kay makabalo na gyud ka og unsa nga kuan, kung makabalo ka na ka sa characteristics sa microorganism nga naka-infect, and also unsa nga antibiotics ang resistant niya dayon or sensitive. So maglanta ka dili sa sensitive nga part. Kung makakuha nimo then based nimo on guidelines, kung like for example sensitive siya to cefepime, a fourth generation cephalosporin. So paglantaw nimo dito sa guideline is naa po ang fourth kanang kuan cefepime nga treatment ba sa katong national antibiotic guideline. So mao na to siya ang mo na to sa i-apply sa doctor nga bagong antimicrobial treatment for the patient. And i-monitor nila, dayon i-kuhan og adverse reactions and pharmacokinetic profiles, and then i-consider po ang cost, then para makuan until nga maayo ang patient. So classification of antimicrobial drugs. The first one is the effects on cells. Katong as mentioned by Ma'am Jeffa ganina, there are two types of bactericidal drugs and bacteriostatic drugs. So bactericidal drugs are drugs that actually kill the microorganisms or the bacteria. Then the bacteriostatic drugs are drugs that inhibit bacterial growth but does not kill them. So sa bactericidal gyud ang gikill makill gyud sa makill good sa antimicrobials ang mga microorganisms. Then sa bacteriostatic is murag dili niya kuan dili siya makill, so naara gyapon mo padayon ra gyapon ang katong previous nga ng mga nabuhi nga mga bacterias, but inhibit ra niya ang growth sa kuan, inhibit ra ang growth sa microorganisms. So nakoy question ninyo, if kuan, if ang patient is immunocompromised, unsa nga kuan, unsa nga classification bactericide of antimicrobial drugs ang imong gamiton, bactericidal or bacteriostatic? Anyone was an idea? If immunocompromised ang patient, meaning down ang iyong immune system, unsa imong gamiton nga kuan kanang antimicrobial, bactericidal or bacteriostatic? Anyone? So kinsa ra nga idea? Like for example, imong patient is a cancer patient nga nag-chemo. So immunocompromised siya, immunosuppressed,
Static kata sir.
and also kisa to si Jade? Oh. Hello? Kisa na idea?
Bactericidal sir.
Bactericidal. Yes, correct. Dapat bactericidal ang imong kuan. Bactericidal ang imong antimicrobial na gamiton for compromised na patients. Kay if bacteriostatic siya, kay dili man niya i-kill ang kuan. Dili man niya i-kill ang katong microorganisms na naka-infect sa bacteriostatic. But i-inhibit ra ang bacterial growth. So naragya po yung mahabilin nga kuan. Naragya po yung mahabilin nga microorganism na maka-infect sa patient. But immunocompromised man si patient, immunosuppressed man siya, yung immune system nga unta mo act ato nga mga nahabilin nga mga kanang bacteria is kuan impaired man siya. So mag-continue ra gyapon ang infection sa patient kay wala man siya kanang natural way of combating those infections. So dili gyud ta dapat nga mo dili gyud dapat nga mogamit og bacteriostatic drugs for immunocompromised patient. Dapat bactericidal gyud siya kay kanang yun nga antibiotic nga actual kill sa microorganism kay wala may impaired man ang immune system sa patient, so wala dili maka-act ang iyahong immune system. So the second classification of antimicrobial drugs is range of activity. So there are two types. You have the broad spectrum antibiotics active against a wide variety of microorganisms. Then the narrow spectrum of antibiotics, which is active against a particular group of microorganisms. So ang broad spectrum, these are usually kaning mga restricted antimicrobials na to is they are broad spectrum antibiotics. So daghan sila og coverage for microorganisms, na uban nga covered pud sila to mga anaerobes ana. Dayon ang mga narrow spectrum antibiotics kanang ang ilahong spectrum is murag kanang ubos ra for particular group or microorganisms sa sila. So dili kayo sila usually sa empiric therapy ang gamit gyud is ang mga broad spectrum antibiotics kay wala pa man kakabalo og unsa nga microorganism ang imong imong naka-infect sa patient. So there are times na for example sa emergency room like nag-uban nga magpe-personal tizobactam na sila or mag-meropenem ang kay doctor kay murag maano ra pang pod na kay tungod nga murag grabe na pod ang assessment nila is grabe na pod ang
infection sa patient. So, kailangan mag-broad spectrum nga antibiotic yun sila. So, then the third one, classification, is a site of action. It affects the integrity or the synthesis of the kanang microorganism. So sa site of action, we have cell wall synthesis inhibitors. Next slide. So this slide is all about kanang gram-negative bacteria and gram-positive bacteria. So we have the gram-negative bacteria are like the examples are the gonococcus, the veillonella, meningococcus, chlamydia, rickettsia, vibrios, escherichia, helicobacter, spirillum, and the spirochetes. The gram-positive bacteria are the pneumococci, streptococci, staphylococci, micrococci, actinomycetes, bacilli, clostridia, corynebacterium, listeria, and bifidobacterium. Who can give me an example of example Helicobacter, most common niya is Helicobacter pylori, H. pylori, which is the etiologic agent for kaning peptic ulcer disease. So this Helicobacter is siya kanang maka-live siya in very acidic na environment, like for example sa stomach nato. So if naka-peptic ulcer disease, most likely ang is i-test ka for Helicobacter pylori or H. pylori. So mo na siya. Then sa mga, like for example, mga gram-positive bacteria, mga pneumococci, mga listeria, monocytogenes, then the corynebacterium, listeria, clostridium, bacilli, Then let's go over to the antibacterial drugs. The first type of antibacterial drugs is the cell wall synthesis inhibitors and beta-lactamase inhibitors. So these are the penicillins, which includes the natural penicillins, the anti-staphylococcal penicillins, aminopenicillins, and the anti-pseudomonal penicillins. We have also the cephalosporins, which is classified in the first generation, second generation, third generation, and fourth generation. We have the carbapenems and monobactams, like the imipenem, cilastatin, and astronam. Other antibiotics, we have vancomycin, cycloserine, and isoniazid. Then beta-lactamase inhibitors, we have the clavulanic acid, the sulbactam, and the tazobactam. So these are the suicide inhibitors for your beta-lactamase. So the first one is the penicillins. The natural penicillins are the penicillin G, the penicillin V, the PenG-procaine, and the PenG-benzathine. Then the anti-staphylococcal penicillins are the methicillin, nafcillin, oxacillin, decloxacillin, and cloxacillin. Aminopenicillins, we have the ampicillin and the amoxicillin. Then the anti-pseudomonal penicillins, we have the mesloxilin, piperacillin, aslozilin, carbonicillin, and ticarcillin. So the natural penicillins, it is used for the gram-negative, gram-positive, gram-negative spirochetes and anaerobes. So these are usually for pneumonias caused by strep pneumoniae, pharyngitis, and scarlet fever by strep pyogenes, syphilis. We have Treponema pallidum. Also for the treatment of meningitis from Neisseria meningitidis. Then for the treatment of diphtheria from Corynebacterium diphtheriae. Then natural penicillins are also for the anthrax or the from the etiologic agent Bacillus anthracis, and also for gas gangrene from the infection of Clostridium perfringens. So these are the natural penicillins, mga penicillin V, Pen-G, benzathine penicillins. So anti-staphylococcal penicillins like the methicillin, nafcillin, oxacillin, dicloxacillin, and oxacillin are used for narrow spectrum penicillinase producing staphylococci and not for the gram-negative staphylococci. So, methicillin and dicloxacillin are the most resistant to the beta-lactamases. So, dili kayo ni sila kuan, dili kayo sila kanang gamit din kayo. So, nafcillin is best with patients with renal failure. Then the vancomycin is given to those with methicillin resistant S or use for MRSA. So vancomycin is not an anti-staphylococcal penicillin, but it is used for as a koan, drug of choice for methicillin-resistant Staphylococcus aureus or MRSA. So, maghisgot na gani og MRSA, kung ano gina siya, vancomycin na dyan siya. Although, pwede mo gamit og uban nga mga clindamycin, na. So, cloxacillin is for the treatment of soft tissue infections. So, aminopenicillins, we have the ampicillin and amoxicillin. It is used for gram-positive, like the Streptococcus, Staphylococcus, Enterococcus, Clostridium, and the gram-negative bacteria like E. coli, Haemophilus influenzae, Helicobacter pylori, Salmonella, for the treatment of upper respiratory tract infection and lower respiratory tract infection, for the urinary tract infection and gastroenteritis. Note, can be combined, these penicillins can be combined with beta-lactamase inhibitors like sulbactam for ampicillin sulbactam, so ampisul, naa siya'y kuan, beta-lactamase inhibitors. Then si coamoxiclav, we have clavulanic acid for amoxicillin. So, familiar naman mo o
Excuse me, sir.
beta-lactamase, no? Yes.
Sir, wala nag-move ang slide, sir.
Okay. Asa mo lapit? Inyo makita.
Sa mga gram-positive ug negative nga bacteria pa lang, sir.
Ay, as in? Time pa ha, for a while. Kana,
Wala pa makita, sir, sa slide.
wala, for a while ha. Um, makita ninyo?
Makita na, sir. Thank you, sir.
Makita na. Okay. Thank you.
Yes, sir. Makita na, sir.
Thank you. So, we have the aminopenicillins, which
Sir,
is the ampicillin and
harapit, sir.
amoxicillin.
Na-stop sharing na po ka, sir.
Stop siya.
Yes, sir.
Okay. For a while na. That one.
Naano, sir.
Na. Okay. So, um, Aminopenicillins like ampicillin and amoxicillin is used for gram-positive and gram-negative bacteria for the treatment of upper respiratory tract infection and lower respiratory tract infection, UTI, and gastroenteritis. It can be combined with beta-lactamase inhibitors like ampicillin, sulbactam for ampicillin, and clavulanic acid for amoxicillin. So we have the combination of ampicillin sulbactam and co-amoxiclav for amoxicillin plus clavulanic acid. So, anti-pseudomonal penicillins. Anti-pseudomonal penicillins composed of meslocillin, piperacillin, azlocillin, carbenicillin, and ticarcillin. So, most common diri sa pharmacy is piperacillin. Usually, kanang ginagamit na kuan generic. But we have ticarcillin plus clavulanic acid also, pero wala kayo gagamit. So they are used for gram-negative like serious pseudomonal infections. It can be combined with beta-lactamase inhibitors like tazobactam for piperacillin, and clavulanic acid for ticarcillin. So please note ha nga um, these mga tazobactam or clavulanic acid are not these are not antimicrobials or antibiotics ha. They are kuan lang sila, beta lactamase inhibitors. So di ba, familiar man mo with beta lactamase nga enzyme no, nga i-produce sa either sa cephalosporins or penicillins, di ba? No, i-produce sa i-produce sa microorganism para mahimo silang resistant to penicillins and cephalosporins, diba? If beta lactamase producing na ang imong microorganism, nagitagaan nimo siya og like for example piperacillin ra or like for example piperacillin or ampicillin ana, dili siya maka-act ang imuhong gihatag nga kanang antibiotic kay susceptible kuan man sa resistant man sila to the beta lactamase. Na may beta lactamase nga gi-produce ang microorganism, so dili na maka-act. Murag mao na siya ilahong, ang beta lactamase is murag ilahong shield sa mga microorganism para dili sila madutlan atong mga antibiotics. So in order nga maguma to nga shield, para mawala ang beta lactamase enzyme, so ginatagaan sila ang imong antibiotic is kitagaan hatagan siya pod og kanang beta lactamase inhibitor. So this beta lactamase inhibitor is murag siya suicide inhibitors nga mo suicide sila para lang maka-act ang imong antibiotic sa sa patient's infection. So like for example piperacillin tazobactam, piptazo, mag-suicide si tazobactam para maka-act si piperacillin sa infection and also para ma-eliminate ang microorganisms. So these are beta lactamase inhibitors. So beta-lactamase inhibitors or suicide inhibitors are used to extend the spectrum of other beta-lactam agents for gram-positive SRUs, gram-negative H. influenzae, and anaerobe Bacteroides fragilis. So amoxicillin and clavulanic acid or augmentin for methicillin-sensitive SRUs or MSSA, ticarcillin plus clavulanic acid or timentin for methicillin-sensitive SRUs, ampicillin plus sulbactam or unacin, ampimax, and silgram. Then piperacillin tazobactam, we have that brands like tazocin, piptas, and vigosides. So these antibiotics have beta lactamase inhibitors. So The second cell wall synthesis inhibitors are the cephalosporins. So we have the first generation cephalosporins. We have the cephalothins, cephaloxime, cephrodine, cefapirine, cefadroxil, and cefazolin. Um, Not very common siya nga gamiton sa these mga first generation cephalosporins are not common siya diri sa hospital. But cefazolin, usually ang cefazolin kanang nay usahay nga mo prescribe na mo og cefazolin kay mo'y gamiton sa mga doctors for kanang kuan gani pre-op nga antibiotic. So prophylaxis siya sa kuan sa operation. So before mag-operate ang doctor, so ang patient tagaan og kanang tagaan siya og kuan prophylactic na antibiotic. So usually sa any uban nga doctors na kuan sa Fasolin ang ilahong gamiton nga first kanang kuan antibiotic for prophylaxis for operation. Then we have the second generation cephalosporins like cefamandol, cefaclor, cefirocime acetyl, ang oral na cefirocime, cefonicid, cefoxetine, cefotetan, ceprosil, ceforanide, cefirocime, ceforamide, and loracarbef. So sa second generation cephalosporins, we have ang available diri na mo is a cefirocime na oral, acetyl, then ceftriaxone na IV of cefoxetine. Yes. And the third generation cephalosporins are the cefotaxime, ceftazidime, cefoperazone, ceftizoxime, ceftriaxone, cefixime, cefodoxime proxetyl, cefdinir, and ceftibutane. So ang available readily pod is cefotaxime, ceftazidime, ceftriaxone, cefixime. So cefixime is ang oral ra siya nga form. Si cefixime usually siya ang himuon nga kanang kuan substitute ni ceftriaxone if for example nag-ceftriaxone ng patient then murag okay na ang patient to kuan to go home. So para continue ang iyong antibiotics, usually kung nasa ceftriaxone siya diri sa hospital, usually ang i-prescribe sa doctor kay since IV raman ang ceftriaxone, so ang i-prescribe sa doctor nga oral nga kuan for continuation of antibiotics is ang cefixime for ceftriaxone. So si cefixime katong Tergicef is kuan available in 200 milligrams and 400 milligrams na kuan preparation. Then the fourth generation is cefepime. So we have cefepime. Ang fourth generation cephalosporin is considered a restricted antimicrobial. So restricted si cefepime, we have Axera. So, siya available. Then, ang spectrum of activity for cephalosporins are more first generation is more on the gram positive than the gram negative. So we have the organisms na spec, we have Staphylococcus, Streptococcus, Proteus, E. coli, and Klebsiella. So clinical uses or adverse effects, we have for the treatment of UTI and pneumonia. For adverse reactions, we have cephalothine is nephrotoxic. Then for Clostridium difficile colitis, we have hypersensitivity reactions. So the second generation cephalosporins, we have the hand spec. Ang iyang activity is equal siya on the gram positive and the gram negative. So organisms are the hand spec. We have the Haemophilus, Enterobacter, Neisseria, Serratia, and others. Then second generation cephalosporins are used for the treatment of meningitis, sinusitis, and otitis media. So third generation cephalosporins are activity nila is more on the gram negative bacteria. We have organisms like Bifenspec, we have Borrelia, Pseudomonas, and others. It is used for the treatment of Lyme disease, meningitis, and gonorrhea. So adverse drug effect niya is bleeding. Fourth generation cephalosporins, more ang iyang spectrum of activity is more on the gram-negative. So, organisms na susceptible are the Pseudomonas, Enterobacter, Staphylococcus, and Streptococcus. So, it is used for the UTI, skin infections, and pneumonia. So, another soluble synthesis inhibitors are the carbapenems and monobactams. For the carbapenems, we have the imipenem and cilastatin combination and also the meropenem. Spectrum of activity nila is for aerobic and anaerobic gram-positive and gram-negative organisms like the Pseudomonas aeruginosa, Bacillus fragilis, not methicillin resistant, not for the methicillin resistant SRUs or MRSA. So adverse effects nila sa carbapenems is for infections resistant to other meds, if high doses causes seizures. So we have carbapenems like meropenem, like mga Merop, Meromax, Meronem. Then imipenem cilastatin, we have an only brand is Chanam. Then imipenem statin combination, imipenem binds to plasma binding proteins like beta-lactams, inhibits soluble synthesis, but it is a bactericidal antibiotic. Cilastatin inhibits the hydropeptidase, an enzyme in the proximal tubule border which hydrolyzes imipenem. Then cilastatin has no antibacterial activity. So, astronam. Astronam is a type of monobactam. Its spectrum of activity is for aerobic gram-negative RADs, but not for gram-positive or anaerobes. The organisms na susceptible is Pseudomonas aeruginosa and Serratia. Then adverse effects niya is for patients allergic to penicillin. They have skin rashes, then STs. So other soluble synthesis inhibitors, we have isoniazid or the INH. This is a type of kanang anti-TB drug. So mode of action is inhibition of mycolic acid synthesis in the cell wall. Then spectrum of activity is for Mycobacterium tuberculosis or the TB bacilli. So clinical uses and adverse effects. It is used for the 4-drug regimen for pulmonary TB, which is composed of the RIPE or the rifampicin, isoniazid, pyrazinamide. And EMB for new smear and then plus PTB taken for 6 months to 4, including the 4-drug regimen for PTB. So RIPE is composed of rifampin, isoniazid, pyrazinamide, and ethambutol. These are for the new smear positive TB taken for 6 months. So adverse effects nila is peripheral neuritis due to vitamin B6 deficiency. So usually ang ginahatag for peripheral neuritis is for wala man gyud kanang di kayo available ang vitamin B6, di ba? So makabantay mo nga naay mga patients nga ga take og anti-TB drugs, so tagaan na sila og usually vitamin B complex kay to combat the peripheral neuritis na adverse drug effect sa sa tambal. So usually makabantay mo na dili na usahay nga na patients na ginatagaan o fixed core na afford na siya ipakapin nila nga vitamin B complex. Even sa mga community pharmacies, usual po na combination na kanang mo prescribe o kanang HRZE plus vitamin B complex. So for hepatotoxicity, for anemia of ethambutol. We have optic neuritis or blurred blindness. Then peripheral effects to vitamin B6 deficiency. I'm sorry na meron na double na. So, we'll now go on with antifungal drugs. So, first class of antifungal drugs is for the alteration of cell membrane permeability of the fungi. So, atong mga antifungal drugs are, we have polyenes, we have the amphotericin B, and also the nystatin or and another type of antifungal drugs is mga azoles. We have ketoconazole, fluconazole, iconazole, miconazole, and clotrimazole. Si miconazole is usually for oral nga katong oral flushes, itong treatment sa mga luas. Si clotrimazole is topical na antibiotic for the treatment of mga tinea, infections. Then other miscellaneous antifungal drugs are flucytosine, rifamycin, and terbinafine. So the polyenes. The polyenes, mode of action niya is positively charged amino groups like ionic detergents disrupt phospholipid structure of the cell membrane. So one type of polyenes is the amphotericin B. It is used for life-threatening systemic fungal infections, binds to ergosterol. It is a fungistatic. It is administered intravenously. It is nephrotoxic and hepatotoxic, may increase AST and ALT. So, amphotericin B cholesterol sulfate complex, a type of amphotericin B, including amphotericin B lipid complex and amphotericin B liposome. It is used for severe fungal infections in patients intolerant of conventional amphotericin B. So, kani si amphotericin B cholesterol sulfate complex, lipid complex, and amphotericin liposome. Mao ni siya nga class of amphotericin B nga katong mga mahalo ni siya kay like for example, amphotericin B liposome is murag mukuan siya sa mukross siya sa blood-brain barrier. Then lipid formulation decrease toxicity by 20 to 30%. So si amphotericin B is considered as a restricted antimicrobial. Di ko sure if nakaabot pa mo naami stocks of amphotericin B, but nag-carry niya na diri sa pharmacy. Kay si Doktora Cirilio for pediatric patients, kung naa mga previous years, naa siya po yung mga patients nga na severe fungal infection. So, amphotericin B ang iyang gigamit. So, we have the azoles, mga ketoconazole, fluconazole, itraconazole, miconazole, and clotrimazole. So, ketoconazole is active against the cyanobacterial harmful algal blooms or the CHABs, which includes the blastomyces, and it is for ang iyahong koan is for ang oral na ketoconazole. Adverse effects niya is GI effects, nausea and vomiting. So fluconazole, it is the same, penetrates the CNS. It is available as an oral and IV. So same siya nga with GI effects of nausea and vomiting. Itraconazole for cyanobacterial harmful algal blooms and tinea infections. So it is available oral and IV. Adverse drug effect niya is same as nausea and vomiting. So miconazole is same siya nga kuan for tinea infections. It is available topical and IV, and there are few reports of adverse effects. Then clotrimazole is for the dermatophytes, so it is used topically, and adverse effects niya is few reports ra ang sa adverse effects. So miscellaneous antifungals, we have the flucytosine or the pyrimidine analog 5-fluorouracil. It is used for cryptococcal and Candida infections together with amphotericin B. It is used orally and it is a narrow spectrum antifungal. Adverse effects niya is bone marrow depression. We have the leukopenia and thrombocytopenia, and also it can cause hepatitis. So griseofulvine, clinical use niya is for dermatophytes like the ringworm, the dermatophytes in the skin, hair, and the nails, and it is administered orally. So adverse effects niya is headache, it is hepatotoxic, and it may cause GI irritation. So terbinafine. Terbinafine is also for the treatment of dermatophytes for the skin, hair, and nails, and also including the ringworms. Adverse effects niya is hepatic effects like hepatitis, hepatic failure, and the Steven-Johnson syndrome. So those are the antifungals. So the second type of classification of kuan second classification of antimicrobials na kuan is inhibition of protein synthesis. So there are two types of protein synthesis. We have the katong others are classified as a 30S ribosomal subunit inhibitors. We have the aminoglycosides. They are bactericidal. Then we have also tetracyclines, which are bacteriostatic. And also there are antibiotics na mukuan sa 50S ribosomal subunit. So we have the chloramphenicol, which is bacteriostatic, macrolides as bacteriostatic, and nicosamines as bacteriostatic antibiotics. So protein synthesis inhibitors, we have aminoglycosides. We have streptomycin, gentamicin, tobramycin, amikacin, metilmycin, neomycin, and kanamycin. For tetracyclines, we have tetracycline given generic, then doxycycline, minocycline, demeclocycline, and oxytetracycline. We have chloramphenicol, then we have the macrolides like erythromycin, clarithromycin, and azithromycin, then lincosamides like clindamycin and lincomycin. So aminoglycosides. Streptomycin is used for TB, for the treatment of bubonic plague, for the treatment of streptococcal endocarditis. It is administered intramuscularly. Adverse effects niya is allergic skin reactions. So better use neomycin. For gentamicin, we have it is used for pneumonia by Pseudomonas aeruginosa. It is also used for UTI, Acinetobacter, Sriracha, and it is administered intravenously, intramuscularly, and topically. So adverse effect niya is neuromuscular blockade, contraindicated with patients with myasthenia gravis and hypocalcemia. So we have tobramycin. It is administered IV or IM, more active versus Pseudomonas than the gentamicin. So, mas preferred si tobramycin than gentamicin sa treatment of Pseudomonas. Adverse effects niya is inactivated when physically mixed with beta-lactams. Then, another type is amikacin, which is available, given intravenously and intramuscularly. So, amikacin has the broadest antimicrobial activity of all the aminoglycosides. Adverse effects niya is nephrotoxics, including the blood urea nitrogen and COR. It can cause increase in blood urea nitrogen and serum creatinine, but it is reversible. Metilmycin is the least autotoxic aminoglycoside. It may cause also ototoxicity, optic nerve toxicity from streptomycin. So, neomycin, it is used for bowel sterilization in preparation for surgery and also for the skin infections. It is administered orally. Then kanamycin is for oral and used orally and topically, and IV also. It is used for preoperative bowel preparation. So, these aminoglycosides causes ototoxicity. So, streptomycin is very more ototoxic than amikacin and than metamycin. So, nephrotoxicity, ang neomycin is more nephrotoxic than the gentamicin and more than the streptomycin. So these are the aminoglycosides. We have tetracyclines. Tetracyclines, generic names niya is tetracycline, doxycycline, minocycline, demeclocycline, and oxytetracycline. Clinical uses niya is for gram-positive, gram-negative bacteria and also anaerobic bacteria like the Vibrio cholerae, acne, chlamydia, ureaplasma, mycoplasma, tularemia, and Borrelia burgdorferi, and rickettsia. Adverse effects sa tetracycline is tooth and bone discoloration sa katong mga bata na less than 8 years old ata na. Oh, yes. This is contraindicated for children less than 8 years old. Okay, it will cause tooth and bone discoloration. Very kuani siya sa if mga bata na mga kuanan sa o tetracycline sa ilahong teeth mo na yung marang magputik-putik na kuan discoloration. It also causes GI irritation, and it may also cause Fanconi syndrome, which is the ingestion of expired drug. So hematologic siya. It may also cause vertigo and dizziness from minocycline. Also, very contraindicated for pregnant and lactating women. So, chloramphenicol, uses niya is, it is a bacteriostatic, and it is bactericidal for Haemophilus influenzae in children. Then, it is used for typhoid fever, anaerobic infections, rickettsial diseases in children, and pregnant women. Adverse effects niya is aplastic anemia due to bone marrow suppression. Then the gray baby syndrome, which causes cyanosis, vomiting, green stools, and vasomotor collapse of the babies. So it is not a first-line drug. So macrolides and lincosamides. For the macrolides, we have clarithromycin, azithromycin, and erythromycin. It is used for aerobic gram-positive bacteria. It is also used for pneumonia caused by Mycoplasma pneumoniae, for pertussis from Bordetella pertussis, Legionnaire's disease from Legionella pneumophilia, diphtheria from the Corynebacterium diphtheriae, chancroid from H. ducreyi, then tetanus infection from Clostridium tetani. So adverse effects is nausea, vomiting, GI upset, and diarrhea. And it will also cause cholestatic hepatitis in the liver. So, lincosamides, we have the clindamycin and lincomycin. Clinical uses niya is for gram-positive and gram-positive microorganisms and Bacillus fragilis. It is also used for prophylaxis in orthopedic surgery and treatment of osteomyelitis. So, very common sa clindamycin for the treatment of acne. So, usually, di ba, kung naay mga acne ang patient, di ba, kanang mga pimples, itong mga grabe na gid kayo murag magpula-pula na gid ang sa patient. Usually, very effective na clindamycin. Mo gina siya yung drug of choice for acne na orally na siya. Pero orally siya, dili siya ihatag topical. Di gud siya ihatag topically. Like katong himuon siya o kanang butang siya sa mga Eskinol na sana usually nasa community pharmacy pa palita kung dalasin si siya. Mayroon po ka nga pharmacist. Naka-reseta mayroon po ang patient niya. Ay, ma'am, ako lang may ibutang sa kuan. Usaraman ka bukay akong ibutang sa Eskinol kay para treatment sa pimples. So, ang buhaton ni mo ana is dili gyud gyapon ka mohatag sa patient kung wala gyud gyapon sila ay kanang prescription. So, even if may siya mo insist siya nga para ra gud sa mo insist siya kay para ra gyud ako no sa ibutang sa mga Eskinol para treatment sa pimples, but dili gyud gyapon pwede. So it is also clindamycin also used for pneumonia from pneumocystis carinii na pneumonia. Then adverse effects niya is pseudomembranous colitis due to Clostridium difficile, and it will also cause skin rashes. So the other type of antimicrobial is for the inhibition of nucleic acid synthesis and replication. So this class of antibiotics include the fluoroquinolones, rofloxacin, norfloxacin, lamifloxacin, ceftriaxone, rofloxacin, and nalidixic acid, the first quinolone. So we have also the rifampin or rifampicin. So we have the fluoroquinolones. Fluoroquinolones include ciprofloxacin or floxacin. Clinical uses nila is for gram-positive and gram-negative extensive but not anaerobic bacteria. So gram-positive and gram-negative siya but not for anaerobes. So ang clinical uses also is for the treatment of urinary tract infection, especially mga ciprofloxacin, prostatitis, also for respiratory infections, nosocomial infections, GI infections from E. coli, Shigella, and Salmonella, Dayon, chronic bone infections like Pseudomonas and Staphylococcus aureus, and for diabetic foot infections, so katong mga cellulitis na. So, very common ni siya ang ciprofloxacin katong magkalibang nga ang patient, mag-diarrhea, possibly from E. coli, so tagaan din siya o ciprofloxacin or mga levofloxacin. So, fluoroquinolones are not very well tolerated. Usually po ni sila is kanang from last line na good if wala na good siya antibiotic na para for that infection kay these are dagan kayo siya ni siya mga adverse effects like it will cause headache and dizziness, then also it will may cause nausea and diarrhea, and it is not for children because of cartilage damage. So another type of nucleic acid synthesis inhibitors is rifampicin or rifampin. It is used for tuberculosis combined with isoniazid, pyrazinamide, and ethambutol. So CR rifampin or rifampicin ang R sa RIPES na acronym. So it is for new smear na positive na pulmonary tuberculosis. It is also used for meningitis and also for the treatment of leprosy from Mycobacterium leprae together with the antibiotic of treatment of choice for leprosy, which is the dapsone. So it is also for Legionnaire's disease from together with erythromycin. So adverse effects niya is very common red-orange colored secretions, like imuhong sweat, tears, urine, and feces are red-orange colored. And it will also cause flu-like syndrome. We have chills, fever, and myalgias for 1 times or 2 times weekly intake of rifampicin. So let's go over with the tuberculosis treatment. So ang treatment diri sa TB treatment diri sa Philippines is usually libre na siya ang TB treatment diri sa Philippines. Okay, ang TB infection diri sa Philippines is very endemic diri sa Philippines. Mostly there are sa epidemiology niya is daghan kaayo nga Filipinos infected with tuberculosis. So, ang wala ka kabantay, wala ka kabalo nga kanang musakay ka og pedicab or sakay ka og jeep or possible ang imuhong tapad is pwede mag-uubo siya, but possible po na nga TB na diya ito. Because TB is very endemic to the kids. Murag makuyawan man gani na like for example ang Amerika, makuyawan gani sila nga kuan kanang makasulod sa ilahon nga ilahong country ang kanang people with kanang like for example mo kanang kaning kuan special SA o Canada muna mo require gina sila before sila mo grant o visa sa kuan. Like for example, mga Filipinos, before na sila mo grant o visa sa mga Filipinos is kailangan ginaog medical. And one component of the medical is kuan, medical examination is kanang kuan, X-ray yun na siya. X-ray yun na siya dayon. If makuan gani ka nga sa imo X-ray is kanang kuan na ay spot ra gani gamay ra gani kayo nga spot ana is kuno din ka sa doktor ikuan gid ka ana og sputum test gid ka dayon ana nila dayon if kuan pangayuan pug ka if nakay history of kuan pulmonary TB pangayuan pug kanila ana nga og kanang murag kuan medical certificate from your kanang pulmonologist na kuan na ayon na gid ka sa imong TB. Then sputum test yun na siya, kailangan mga negative na siya. Muna upo na usaha sa mga kanang mga abroad gani nga kuan mga abroad ng mga Filipinos na mura sa sila kadlukan na kanang na makita nga spots sa ila sa chest X-ray nila. So TB is very endemic diri sa Philippines as kuan. Sa endemic niya is naan ang DOH or the Department of the Philippines hatag na siya og kanang libre nga treatment for pulmonary tuberculosis. So ang ilahong strategy for sa DOH for TB treatment is the DOTS initiative, which is the directly observed therapy short course for first-line drugs for anti-TB. So, sa directly observed therapy short course, ang mga patients may enroll sa mga DOTS accredited na centers, like for example sa hospital. Diri sa SCMC na apod ni TB DOTS Center diri sa likod katong naay murag sa likod gyud siya sa kuan dapit sa MAG building or katong dili dapit sa tunay mga parkinganan gini o mga sakyanan sa sulod katong duol siya sa anang dining hall or sa canteen kada atbang diha nga hatong naay building pag diha naay diha ang TB DOTS Center sa CMC naapoy naay ga-duty diha nga nurse, then naapoy ga-duty diha nga kuan kanang medtech kay siya may mag-perform sa sputum test. Dayon, it is under sa community medicine sa hospital. Then, apon may mag-rotate diha ng mga kanang mga JIs, mga junior interns, mga medical interns, junior interns, and also mga PGIs. Kaya that is part of their kanang kuan man. That is part of their internship man ang community medicine. So, na sila diha mag-counsel na sila sa mga TB patients nga magkuha sa ilang mga tambal. Yun na. Sa una is ang sa una gyud is stricto gyud kayo ang kanang DOTS center nga kailangan everyday gyud mo everyday gyud mo adto ang patient para mo inom sa iyang tambal. Kay directly observed man ni part of the directly observed is itong nurse or kinsa nga naa sa DOTS center is siya kita sa patient nga iyang giinom gyud sa patient ang tamba niya. Kaya that is part of compliance, di ba? Sa atong mga pharmacist is ginatudloan pud ta og kanang kuan compliance to monitor compliance sa mga patients, di ba? Sa clinic, I'm not sure if sa clinical pharmacy ba na or basta di ba na ay subject sa inyuhon nga kanang itudloan ka o kung saan pag-monitor sa compliance sa patient through phone calls, So, that is a DOTS initiative, so directly also siya. Pero karon murag, nakin ako na pwede sila muhatag at least for 1 week na kuan, 1 week plan for sa patient na di 1 week supply siya. Horot na siya, then you're planning din for the next week. Pero, i-monitor na po nila ang treatment sa patient. Kay, one of the very pinaka-goal yun sa kanang TB treatment is ang compliance good siya. Kay, TB is very curable, pero dapat continuous gid ang ihang daily gid ang ihang kuan kanang pag-inom sa patient. So for MDR-TB, multi-drug resistant tuberculosis, we have the TB bacilli that are resistant to kuan isoniazid and rifampicin. So if kuan ang if 2 of the right na kuan regimen is resistant to if ang microorganism TB microorganism is resistant to isoniazid and rifampicin, that is now called the multi-drug resistant tuberculosis. So, kailangan na siya og second-line TB drugs, which includes the aminoglycosides, polypeptides, fluoroquinolones, thioamides, cycloserine, and para-aminosalicylic acid or PASA. So, the other type of tuberculosis is the extensively drug-resistant tuberculosis. It is where the TB bacilli is resistant to INH and rifampicin, plus at least 3 of the 6 main classes of second-line anti-TB drugs. So, if kuha na siya, resistant na siya sa isoniazid or rifampicin, plus resistant pag siya sa mga aminoglycosides, mga fluoroquinolones, dayon existent po siya sa mga streptomycin, that is considered as the extensively drug resistant TB or the SDI-TB. So another type of antibiotics is for inhibition of enzyme metabolism or folate inhibitors. This includes the sulfonamides, like the sulfamethoxazole, sulfamethoxazole, sulfadiazine, sulfamethisole, sulfasalazine, sulfadoxine, sulfacetamide, silver sulfadiazine, and mafenide. So very common AMI is silver sulfadiazine. Dayon sulfamethoxazole for the treatment of irritable bowel syndrome. And also it includes folate inhibitors includes the trimethoprim. Trimethoprim in combination with sulfamethoxazole, that is your cotrimoxazole. So sulfonamides, it is used for gram-positive, gram-negative bacteria, and it is a bacteriostatic antibiotic. So it is used also for UTI due to E. coli and Klebsiella, but not for Pseudomonas. Then it is used for chlamydial infections, including sulfacetamide. Then also for toxoplasmosis, nocardiosis from nocardia, including sulfamethoxazole. And also for burn infections, we have the silver sulfadiazine, topical na antibiotic. So adverse effects niya is cramp, which is a crystalluria from sulfadiazine. It may include rashes, anemia, nausea, kernicterus, Stevens-Johnson syndrome, and it is also contraindicated for pregnant women and children for
less than 2 months old.
We have trimethoprim. Trimethoprim, in combination with sulfamethoxazole, which is a cotrimoxazole, is very very siya common for recurrent UTIs. So mga kaning cotrimoxazole if naiuban nga kanang kuan is cotrimoxazole ang ilang ihatag for UTIs o mga recurrent kung balik-balik. Munang, ang karon sa mga previous years patong nga data, taas na pud kaayo ang kuan. Taas na pud kaayo ang resistance rate sa kuan cotrimoxazole kay naman po'y uban nga kanang kuan, uban nga patients nga moadto sa butika mayon nga mapalita ko try kay guilty eye ko. Na apoy uban nga mga bulayagon nga mga pharmacies nga muhatag yun po kuan bisag wala reseta. So muna ni taas po ang ihang resistance rates. It is also trimethoprim in combination with sulfamethoxazole is also used for bacterial prostatitis, for the infection of the prostate gland, for treatment of gonorrhea. We have sinusitis or bronchitis, and also pneumonia caused by the Pneumocystis carinii pneumonia. Then acute otitis media for chancroid, for shigellosis, and also for typhoid fever. Adverse effects niya is folate deficiency problems like anemia. Then also it may cause skin rashes and also Stevens-Johnson syndrome. And also, ang GFX niya is nausea and vomiting. So, let's go now with the antiviral drugs. So, antiviral drugs are actually, as the name suggests, it is used for the treatment of viral infections. So, para ni siya sa mga virus. So, there are classes of antiviral drugs, including the antiherpetic drugs, which includes acyclovir, foscarnet, ganciclovir, edoxuridine, and vidarabine. So these are antiherpetic drugs for the treatment of herpes zoster. So antiretroviral drugs or NRTIs, we have sidovudine, we have didanosine, zolcitabine, abacavir, statine. So, antiretroviral NRTIs, we have nevirapine, delavirdine, and efavirenz. Then, NRTIs are nucleoside reverse transcriptase inhibitors, DI. For they are antiretrovirals treatment usually for HIV infections. So we have also antiretroviral protease inhibitors like indinavir, sakinavir, ritonavir, nelfinavir, and amprenavir. And other antiviral drugs like amantadine, rimantadine, sanamivir, oseltamivir, interferons, and ribavirin. Kani sila is antiviral drugs is uses nila ani is for the treatment of flu infections and common eye flu. We have oseltamivir. The very common brand name is Tamiflu. Katong sa COVID pandemic, since COVID-19 virus is COVID-19 is ang biologic agent niya is kanang virus. So natoy tayong murag ni gawas po ni oseltamivir nga kuan for treatment po daw kun mo siya o kanang unsa ni sa COVID infection, but kuan muna order na unta gani mi ato, but kanang ending murag dili ra day pud kayo siya gamit kayo, so wala ra pud mi na dayon order. So antiherpetic drugs, we have foscarnet, edoxuridine, vidarabine, and acyclovir. It is used for genital herpes, varicella, for chickenpox, herpes zoster from shingles, or shingles. Then cytomegalovirus, for CMV retinitis in AIDS patient, we have foscarnet and ganciclovir. Then for herpes, we have acyclovir. Then adverse effects niya is nephrotoxic and neurotoxic at high doses, like for acyclovir, then bone marrow suppression for ganciclovir. So antiherpetic drugs, acyclovir, most common niya is kaning mga hangga, varicella zoster na chickenpox. Dayon kung gulang na, kung ma-reactivate ang varicella zoster infection, kung magkuhan na siya, kung magulang na, kaya hindi na compromise ang patient, so that's the time na mag-shingles na siya or herpes zoster, or katong more commonly, sa atong dialect is kanang likus-likus gani. So katong murag diri ang iyahong kuan is na siya murag kanang mo tubo ng mga lesions diri sa kanang sa trunk kanang sa upper respiratory upper kuan kanang diri sa kaning ano gani murag sa sabi siya kanang sa tiyan na ay murag magkuan diha na ay kung mag-shingles na ay sani kanang murag maglinya nga mga kuan kanang murag magbutod-butod. Unlike sa chickenpox nga naa siya ano kanang iyahong kuan katong mga manubo-tubo is katong all around the body man to siya no. But di ba kay kung like for example kanang if sa imuhong childhood is natakda na ka o nagka-chickenpox na ka, di ba, usually is dili na kang ka matakdan because of immunity. Ay naka-develop na kag immunity kay nakakuha na ka. Then also, ang mga virus ani is dili gyud na siya mawala gyud sa imuhong kuan. Dili na siya mawala sa imuhong system or matulog na siya. Dayon, once nga magulang na ka, dayon immunosuppressed ka, then muna to nga mo reactivate na to nga kuan varicella zoster virus, imo na siya og herpes zoster. So, magkuan na pud ka kanang mag-infection na pud ka, but ang kanang iyahong mga kanang mabutod-butod is dili ralapit sa tiyan. Ang kuan din mga kuan siya kanang murag kanang san siya sakit kayo siya na kuan katong manubo-tubo nimo din usa ra ka line diri sa imong tiyan.
So that is the shingles.
Then she go on nucleoside reverse transcriptase inhibitors or NRTI. Antiviral NRTIs are the sidobudine, didanosine, salcitidine, lamivudine, abacavir, and sidobudine. So clinical uses niya is the treatment of AIDS. AIDS is the condition wherein the CD4 cells of the patient is less than 200 cells per ml plus the presence of opportunistic infection. So if ma-infect ang patient, like for example, na ay patient na infect siya, na siya HIV virus, infect siya with HIV virus. If dili pa na siya matawag nimo og AIDS, di ba? AIDS, more commonly, ang AIDS mo develop siya after 10 years, why? And also, mo develop ra pud ang AIDS kung ang imong CD4 cells is mubo kayo ka, then nakay presence of opportunistic infections. Kung magka-AIDS siya, usually is na pud kay TB. Okay, TB is very endemic dito sa Philippines, so immunocompromised ang patient na naay HIV infection, dayon so matakdan dayon siya og TB. Usually ang gikamatchan sa mga kaning mga HIV patients na ay AIDS na is kanang kuan complications nila sa TB. Kay kuan naing uban nga nami mga previous patients diri sa hospital sa unang anong murag grabe kaayo ang grabe na siya AIDS na dayon kuan kanang kuan nagka-develop na siya og kanang TB, pulmonary TB, then una to gikamatcha niya siya kanang like na magsuka na og dugo ana. So that is AIDS. So ang rule for AIDS is treatment of AIDS is for treat any symptomatic patients. For CD4 normal but suspect HIV infection, do not give an anti-HIV meds. So ang CD4 cells ang kuan murag indicator if na HIV infection ang patient. Kung normal ra siya but suspect ka og HIV infection, so dili gyud ka dapat nga mohatag og anti-HIV medication. So asymptomatic or AIDS for CD4 cells of less than 200 and any value of HIV RNA, that's the time na kuan mag kanang treat na ka. So asymptomatic is CD4 cells of asymptomatic na kuan CD4 cells of more than 200 but less than 350 and any value of HIV RNA, that is for treatment na of kuan kanang antiretrovirals. Then we have asymptomatic for CD4 of more than 350 and HIV RNA of more than 55,000 also. That is treatment rule for HIV infections. So adverse effects niya is anemia, headache, fatigue, and peripheral neuropathy. So like also sa TB infection, diri sa Philippines, so the DOH, ginalibre na po nila ang ginalibre na po nila ang treatment for kanang antiretroviral treatment for HIV patients. So, if magpa-test ang patient, di ba, na may mga counseling ana, then if mag-positive ang patient for HIV, i-enroll na sila o kanang murag center nga nag-dispense og kaning mga antiretroviral drugs. So libre na sila, tagaan sila og like for example, tagduha ka bottles nga kuan katong antiretroviral nga combination. So muna to ilang i-consume for example for 2 weeks na consumption 2 months na consumption niya. So mo to ilang ikuan for 2 months, then after 2 months insya ka na sila nga mubat kung hapit na mahulot ang iyahon na ang iyahong mga antiretrovirals nga stuff, balik na po siya sa center para mo refill na po o kanang kuan antiretroviral drugs. So libre ra na siya. So non-leukocyte reverse transcriptase inhibitors includes nevirapine, dilaverdine, and efagrens. It is used for in combination with NRTIs for HIV treatment. So adverse effects niya is for resistance develops rapidly with monotherapy, Stevens-Johnson syndrome, and dilaverdine is teratogenic. So ang kuan also, if makabantay mo sa mga AMS rounds also, ang anti-HIV nga mga kuan kana makakita gani mo o hindi ko sure if nakakuan ba mo nga na patient na kanang nasay sa iyahong meds sa medication chart niya is naa siya mga kuan mga antiviral na ready ka familiar ana. So pag kuan mo ana kay dili man na nila i-indicate sa patient's chart yun is dili na siya i-indicate na HIV ang patient, na HIV ang patient kay that is very confidential na information. So sa akon nga part nga kanang sa AMS rounds ana is makabalo na lang kung possible na HIV ang patient through his or her medications. Naa siya kanang kuan, naa siya mga antiretroviral drugs na kanang part sa iyang kanang treatment. So kanang mga antiretroviral drugs is dili na siya included sa AMS nga kuan nga katong kailangan o 7th day automatic stop ana nga kailangan sa 7th day form after 7 days. So as is regular sila kay ang treatment nila biya is continuous review na siya with antiretroviral drugs. So dili na kailangan nga after 7 days in admission, dili na kailangan ikuan sa doktor nga kailangan siya nga mo kuan mo gama og 7th day form kay understood naman nga ang treatment niya is good kana moral maintenance na gyud niya for the lifetime of the patient kay since HIV has no cure yet naman. So kaya sa anti-TB drugs na dili po siya appeal sa kanang sa 7th day nga kuan restriction. So, protease inhibitors, antiretroviral also includes indinavir, sakinavir, ritonavir, dalfinavir, and aprenavir. It is combined with antibiotics for HIV treatment. So, code name niya is RAINS, protease inhibitors. Adverse effects niya is resistance develops rapidly with monotherapy, then GI distress, and skin rashes. Hello? Kuan pa ko ninyo?
Yes, sir.
Hello, anyone? Wala pa? Okay, wala lagi siya ni stop ang kuan. Di ba 1 hour ang kanang sa diri sa sa Google Meet?
Yes, sir. 1 hour. Pero,
1 hour na siya.
pero wala
Pero
naman siya.
murag kuan wala naman siya. Pero happy na ko mahuman po noon. I'm on the last slide na po.
Sige, sir.
So,
Thank you.
So other antiviral drugs, includes the amantadine, rimantadine, zanamivir, oseltamivir, interferons, and ribavirin. So clinical uses niya is for treatment of influenza A viral infection, the amantadine and rimantadine, then also for the respiratory syncytial virus, ang treatment niya is ribavirin, then also Kaposi sarcoma, chronic hepatitis B and C. So, mao na sila. So, mga amantadine, rimantadine for hepatitis treatment. Dayon, adverse effects niya, they are teratogenic. It may cause anemia with ribavirin. And amantadine and rimantadine causes GI effects. Then, it also would cause adverse effects for flu-like syndrome for interferons. So, that is all for my koan lecture on permitted antimicrobials. So, now my questions. Hello. Now my questions, everyone. I guess wala ra may questions. Then kadang sa akong exam is sayo na kaya akong exam multiple choice pero naa siya enumeration. So ang enumeration is murag ra pud siya. Okay ra pud siya. So good luck sa inyong exam with cabinet 6 and 7 for this week. Dayon sa kuan po di ay Same as sa previous ng mga kuan, na ko i-send sa space chat nga katong link for the evaluation. So that will serve as your attendance for today for my lecture. Then kung kung kinsa so dapat kamutanan is maka-accomplish ato nga kanang sorry, accomplish ato nga Google form for your attendance. So that is all. Thank you everyone for listening for today. Thank you for today.
Thank you, sir.
Thank you, sir. Goodbye, sir.